We're here today to talk about healthcare. We're joined by three healthcare industry leaders in Wisconsin, also joined by Mark O'Connell of the Wisconsin Counties Association, Jim Wood of Wood Communication. Jim, you're chairman of Wood Communications and Strategic Counsel to Competitive Wisconsin and the BeBold Council.
Yes.
Can you kind of set the table and explain the importance of what we're doing here?
Sure, happy to do it. So Mark, as Mark has suggested, Competitive Wisconsin's goal is to improve quality of life and competitiveness in the state of Wisconsin on behalf of its citizens and institutions. We've been doing that since 1981 in one fashion or another. Most recently, starting in about 2010-11, we started something called the BeBold initiatives. And the BeBold initiatives are a process in which we engage business leaders, folks from the academic community, the expert community, the governmental community, et cetera, to focus on large issues confronting the state of Wisconsin. This is our third BeBold initiative that we're here talking about today. And the assignment this time was to try to identify two large employment clusters that were really contributing to Wisconsin's economy and to its quality of life. And we did that by going to the UW-Madison, UW system and asking for some research help in terms of identifying two clusters that had sustained positive job growth and had capacity for further job growth in the state of Wisconsin. Wisconsin Economic Development Corporation also helped with some of that research as we went forward. And we identified two major employment clusters. One is the healthcare community with us today, and the other, as you know, Steve, is food manufacturing. So we're here today to take a look at the question of what's working for those folks here in Wisconsin. That's where we went with the process. We engaged leaders from the industry to come in and talk with Deloitte, our main research partner in that process. And they spent time doing research, comparative analysis in Texas, New York, Colorado. Came back here, we gathered leaders in a strategic planning exercise. I think we had 40 to 50 organizations, companies, and experts in the process. And they've identified needs and proposals that we'll be talking about this morning.
And one number that stresses the importance of healthcare is 400,000 plus Wisconsin residents work in the healthcare industry?
Yes, at least 400,000 depending upon how you count it. And so they're a major segment of Wisconsin's total employment base. And I actually have some charts we can share with you if you'd like to take a look at those.
I'd love it. Thank you.
Wisconsin's healthcare employment cluster is a critical piece of the state's economy, which is why Competitive Wisconsin selected it as one of the two clusters we were going to focus on in the BeBoldIII exercise. There are basically four reasons for that selection. The first is that it's a major player in the state's economy, and let me put some numbers on that. Our adjusted workforce statewide in 2016 was approximately 3.1 million people. More than 400,000 of those Wisconsin workers, nearly 1 in 8, was employed in healthcare, and they and their employers comprised an economic engine that generated 8% of Wisconsin's gross domestic product in 2015. The second factor that's important from our point of view is that the healthcare cluster employment sector has been growing steadily since 1990. So that this is not a late blooming phenomenon, it is a consistent phenomenon over time. And as a result, Wisconsin now ranks in the top 30 states from an employment point of view in ambulatory care, hospital and nursing and residential home care facilities. The third thing that caught our attention when we were looking at it is that employment in the healthcare industry tends to be a stable phenomenon. And so when you compare turnover rates between healthcare employees and other forms of employment, it's very, very stable. And that's a critical piece of the equation. All of that said, that is that it's a major economic engine in the state, the fact that it's been growing for a long period of time, and the fact that it's a stable factor in our state, all critical. There are, however, two concerns that I think are worth noticing. One is that as the population in our state has aged and grown larger, we have a workforce shortage in the state in terms of our capacity to provide care. And the second area of concern is that when we just look at the age of the workforce and probable retirement issues, in 2015, nearly 1 in every 4 hospital and ambulatory care employees was 55 or older, suggesting that these two sectors will need to replace 60,000 workers within the next 15 years.
Jim, the BeBold identified two major issues, workforce and population health. Can you put those in context for me?
Thanks, Steve. I'm happy to do that. This particular program is focused on population health, which I think is one of the more challenging issues confronting not just Wisconsin, but across the country. And I'm very interested to hear what the folks have to say. As you know, we went through the process, the BeBold process, which means we did research. We had talked to people in the healthcare community about what was working for them in Wisconsin, what was not working for them in Wisconsin, and what was going on elsewhere that might make a difference to the quality of life here in Wisconsin. Essentially, they identified three issues related to population health. The first, which is a little hard to get your arms around, at least it was for me, was that the change going on at the national level in assuring quality of health, which is a shift from payment for services to a shift with an emphasis on payment for outcomes, produced an evaluation that essentially, as I understand it, says that these issues are broader, that they go throughout the entire community, and that if, for example, we spend right now a large chunk of our healthcare dollars on chronic illnesses, that one way to begin to get that under control and provide better health is to go and say, well, we need to cut down the incidence of chronic illness. And that requires rethinking, I think, how you deliver health care and where you deliver it and at what ages you deliver it and so on. So it's a whole different kind of complexity, and that was an issue that they raised. The second issue they raised was that because of changes in our age brackets and in terms of where our workforces and our populations are centered, the current system is under some exacerbation in terms of not just shortage of nurses and doctors, but in terms of shortage in specialists and other kinds of care delivery capacity related to population health. And then the third issue, which is again a challenging one, is that regardless of what you do to address community health issues, whether they're acute care or chronic care or whatever else it may be, those changes are going to take years to impact in terms of revenue streams, in terms of when you start to get the payback on it. And so the question was, what can you do here in Wisconsin? And what the group finally decided was that they would focus on the expediting the recognition of what healthy communities look like and how we would get there based upon all the good work that's already being done. But I think it really became a question of expedition, and then the second major focal point was, how do we pay for this? What is the transition? Where do the transition dollars come from? So it's expediting planning, expediting implementation, I think, is where they finally focused. So that's what we're here to do today.
And we had the opportunity to interview some professionals on this issue, so this is a good time to listen to their stories.
Well, thank you all for being here today. I appreciate you taking time to help us get through this. I know that a number of you have participated in the process all the way through, and I do appreciate that tremendously. We're here to talk today at this panel about population health, which is a descriptive phrase that the profession and others use to talk about how we've been trying to grapple with and adjust to changes in healthcare delivery, healthcare payments, and the demand on healthcare as a result of changes in the country and changes in our community. And I'd like to start there. So let me throw out the starting point. One of the major changes that has driven this interest in population health is the shift from wanting to recognize or pay for services versus wanting to pay for outcomes. And all part of this is the whole concept of quality in health care and so on and so forth. But I wonder if you could help our audience understand what that shift has done and what it means in terms of communities. Yep.
Jim, I would take it one step further in saying I think the message we're getting in the healthcare sector is people want to pay for health. And I always think of it in terms of metaphor of a river or a stream, and we've traditionally been downstream, just taking care of people as they come at us. And it's kind of obvious we have to go upstream now and make sure fewer people are thrown into the river. And that's what population health, both within the clinic and in the community, is all about.
And I think that I would like to say that, as Tim has pointed out, is that we got to work more upstream. And so when we think about population health, especially from a preventive perspective, we're talking about things that traditionally hasn't been as identified so much in a clinical setting. And that, from a public health and a population health perspective, addresses creating a culture of health. And that has to do with looking at what is the nutrition, what is the access, what is the availability for somebody to be able to have housing. What about their economic well-being? All of those things really play into addressing a population of health, and so that we have a continuum of well-being, and how do we get each person to their optimal level of health, whatever that may be.
And so one of the reasons, picking up on Pam's point, one of the reasons that the reimbursement system matters so much to this conversation is, as you just heard, there are many, many drivers of good health that are not within the direct purview of the healthcare delivery system, and I don't think any of us at this table would suggest that it's the responsibility of the healthcare delivery system entirely to take care of all those needs. And yet, if we acknowledge, as I think we do, that health really is that complete state of mental, physical, and emotional well-being, then we don't want to miss any opportunity that we have to make those improvements in people's underlying health and well-being. So that means that by shifting, in this case, healthcare reimbursement more in the direction of outcomes and value, we can, in theory, free up some resources, provide some more flexible resources inside of clinical care to allow for referrals to community services or allow for assessment of the kinds of needs that both Pam and Tim were talking about. That's why the shifting payment system matters so much to this conversation.
I would agree. I think that one of our biggest opportunities is to step up as a country and actually compare ourselves to the Europeans. We spend half as much in social services. And if we can attack this in two ways. The health systems and physicians and nurses and advanced practitioners can work on the high-end costs and reducing that and having good outcomes. But we need to invest on the other end to prevent. Businesses run best by not having emergencies. They run best by preventing emergencies. We have always been the emergencies.
You know, I think that the change is a positive one. We're in an evolution, but we're trying to undo decades of the more we do, the more we make as an industry. But I think we're moving from react and respond to predict and prevent. And we're using big data, medical information systems to, we know precisely what we ought to be doing. 70% of what we're treating in the healthcare delivery system is lifestyle-driven illness, and we know it's treatable, manageable, and curable. So if we can get upstream, to Tim's earlier point, we can predict and prevent some of these diseases and downstream illnesses. We can get a better outcome and spend less money, but it takes an engaged patient, consumer, in being involved with their care. And I think we're spending money today trying to keep people out of the hospital, which is unlike what we grew up in the industry trying to do. The more we do, the more we make. I'm now, as a provider, trying to be in the, today I'm in the healthcare business, tomorrow I want to be in the business of health. And I think that's going to take an awful lot of upstream public health collaboration with partners in the community, and most of all, an engaged patient.
I think it's also important to separate value from population health, because the way we've approached value is how do we decrease the cost and maintain the quality when health care is needed. Population health is really focusing, should be focusing on health and less on health care. And our value and CMS initiatives have actually been to reduce their spend.
But when you talk about upstream, if you will, if you talk about, clearly the reason we use the phrase population health, we are suggesting that others have to be involved in the delivery of health care, or can have an impact on how people get healthy. And so whether that's, as we re-envision how the schools play in that, we re-envision how the individual plays in that, how employers play in all of that. How far down the road are we on that? I mean, it would sound, Bud's suggesting that certainly we haven't changed our reimbursement programs to recognize that. Are we at a point where schools understand they need to be a piece of the equation? Are we at a point where the media understands their role in this stuff?
I think we're still beginning. but we started. Great example, I think, to frame answers to this particular question is the opioid epidemic, which has, I think, accelerated our understanding. We understand it's a healthcare issue. We understand there was overprescription. We also understand it's a criminal justice issue. But I think maybe largest of all, I think we're beginning to understand, particularly in rural areas, it's a disease of despair. And people don't have jobs, they don't have hope, they don't have education. So that begins to get, rightly so, to the root of the issue, but it also simultaneously gets us further away from healthcare. So it's a great example. We will not cure the opioid epidemic without it being a full, hard press by the whole community, by the whole state.
And I would say actually in the rural areas, primarily because of the low income, we don't have as much of the issue with the opioids as we do with meth. And as we talk about hopelessness and despair, I previously had a Fresh Start program that I operated with a coordinator. And I had 17 young men and women who were in that program. And they didn't know when their next meal was going to come. They didn't know where their housing was going to be from. They didn't have supportive families. They didn't have a resilient community to help support them through the challenges that they were going through. And the disparity in that is part of the challenge that we have, is because we've got to flip the way that we're looking at what do we value for that person or that group, that aggregate of people. The other thing that I would say is in regards to rural, but we also have one of the worst African American infant mortality rates here in this city, and we need to look at those disparities and the health inequities in regard to those areas too.
So how do the demographics play into that? Okay, so clearly, in addition to the change from pay for service to pay for outcomes, part of what, as you trying to figure out what that looks like from a financial point of view, from a reimbursement point of view, you got to look at where that does take health care. So in this state, over the next 25 years, we are looking at an 82% increase in the 65 and up population, at the same time that we're experiencing less than a 1% increase in all other segments of the population, okay? Which means that your tax base is going to be eroding unless you begin to deal with those kinds of equations. So at the very point in time that we are turning to community programs and community services, et cetera, we are describing a circumstance where the tax base is under significant pressure. How does that factor into what you see going on now? When you think about in your profession or in your communities or in your professional job, getting and beginning to focus on population health, getting effective about population health, how does that demographic piece touch it in terms of other limited resources? Not priorities haven't been set there. I mean,
Jim, maybe I can start outside of healthcare, and then I'll let those who are more directly involved in healthcare speak to this, because I think it's a great question. What we see in our work is the pressure of what you just described on employers and their ability to attract and keep the workforce that they need. And I know that you've had other conversations with this group about workforce, but it relates here as well, because we're in a situation right now where, just as you're describing, employers cannot fill the jobs they have today. They know, if they've looked at the data, they know that the picture for tomorrow and 5 and 10 and 20 years from now is worse. And so what that means from a population health standpoint is we cannot leave anyone behind. We really never should have been leaving anyone behind as a state or as a country, but now we can't as a matter of an economic imperative. So folks who are experiencing opioid addiction or other substance use disorders, we have to get about making treatment more available, because that is a part of our workforce that we need at work. Kids who are growing up in disadvantage, which we know contributes to poorer economic achievement later on, poorer educational outcomes, we have to be addressing that as far upstream as we can possibly get, because that is our future workforce. So I think there's a whole opportunity to re-engage really every sector of our state, every sector of the economy. And whether you take a population health lens, whether you take a healthcare cost containment lens, whether you take a future workforce availability lens, doesn't matter. The root causes to all those problems are similar, and we need to be working on them quickly and together.
You go ahead.
I think one of the things too is we were talking about the opioid addictions, the meth addictions, and that area of hopelessness and despair and how that really affects the economies of scale. We need to also think about when we don't invest in early childhood initiatives, the adverse childhood experiences. We can't have a productive workforce if that child or that baby is born into an area that they don't have that same access, that they don't have equitable opportunities to education, to resilient communities who they have that chance that if they have a family that is maybe not quite as at an advantage, that they then can move through the socioeconomic ranks and rub elbows with somebody else who can help them get through that period of time that their family may be struggling with. Because as far as I know, after 30-some years of being a public health nurse and working in population health, I haven't had anyone who has signed up to say, I have decided that I want to be this particular way in regard to being addicted to whatever, whatever thing that they might be addicted to, or that they are so poor. And so I think we have to look at this area in many different ways in a large, wide population health lens, but it's going to take some really strong work.
Can we come back to the other demographic, the aging demographic that you brought up, and from a healthcare standpoint? So we know that's a population that uses healthcare rapidly increasing. If it turns out after age 57, you're on an upward use curve.
I could tell you personal stories.
Okay. That's a population, though, that also needs the same social services, but we also have opportunities to age in home. We have opportunities of utilization of care. Do we need everything to be done 3 times? Do we have to be thoughtful what we do offer and what we do test and do things on? Also, this is an opportunity in up in Gunderson's done a really terrific job of actually having advanced directives. What do people want? What do their families want? So that we can actually be thoughtful of what quality of life they're trying to achieve.
The third issue basically says we got to figure out how to prioritize and bring this stuff together. That part of the challenge is because we all care, because we all worry, whether it's opioid or meth or behavioral issues or the aging population. We're in the business, you're in the business of delivering care. That's been the culture of the community for decades and decades. And now we're saying maybe there's not enough to go around, and we have to, what do we do in the next 5 years? What do we do in the next 7 years? And if you look out 15 years, it's a whole different population, okay? And all of those things need to affect some kind of strategy. And so essentially what the BeBoldIII strategic planning group talked about was to focus on planning, if you will, to get some coherence around applauding all the good work that's been done with partnerships and public health and all the rest of that, but saying maybe we're not quite where we need to be in terms of saying, here are the things we think are most important, here's where we are on those things, here's where we need to get on those things, and here are the first 6 things we need to do as a state, as a region, as a community. And essentially what we proposed, what the group has proposed, is that the state and the private sector contribute money to a fairly high-powered planning exercise that gets turned around in a relatively short period of time, and then figure out how you're going to make those things happen. As a footnote on that, the workforce panel, as you know, identified shortage of nurses and doctors as an immediate and pressing danger to public health and the economic well-being. And the new paradigm these days is it's not enough to identify the problem and talk about what you're going to do about it. You have to talk about how you're going to pay for it. And the mechanism that we're looking at there is the monetization of the value of unfilled jobs. And that is looking more and more interesting as a phenomenon, both in terms of the sheer magnitude of money that we lose if we don't do this. And I think the premise is that mechanism would come to this issue. And I'm a long way around to asking you to talk about, so how do we prioritize, for starters? How do we say what is the most important thing? Is it that we figure out how to reduce the ongoing cost of care? Are we really prepared to think dramatically about this? And I'll give you the example I use is clearly early childhood development produces some pretty significant bang for the buck in terms of stuff. So if I take the K-12 system and back it up and make it a birth to 10th grade system, I've got the buildings, I've got the facilities, I begin to think about things, and that's on a different issue that we're working on, but it's related, I think. And so, and I'll throw out one last thought that I'd ask you to talk about. When I look at healthcare expenditures in this country, and you look at the volume of dollars spent on last year of life, and you say, where am I getting the resources and how do these things come together? Somewhere in here, and it's not about death panels, it is about saying, we have a responsibility if we're going to say we have to get here and we have to pay for that because we can see the results. We need to be able to figure out how we're going to capture those results, and et cetera. And so I'd ask you to talk about A, the interest in planning, B, what kind of priorities you think are likely to emerge in that sort of a process, and then C, comment about the value of looking at if we can fill jobs, we get money. If we don't fill jobs, we don't get money.
I can give you a real quick answer. Is when we go to build a clinic or a hospital that's going to last for 30 years, we don't stop seeing patients for 5 years to get the cash to do that. I've been on the State Bond Authority for 30 years. We have a mechanism to get money to invest for the future. And I think we don't have that mechanism currently at all to really be able to go upstream and make a real dent on the patients that are coming at us without the. And I think the report has some recommendations. I think they're very far-reaching. I hope we can get a conversation going in our state around how we capture those dollars to invest in today.
Yeah, I think that there's an awful lot in that question and a lot to cover, but I think one of the things we have to do is really educate our patients/consumers. I think we've enabled them to turn their lives over to the medical delivery system, and we have some of the best care in the world, but not everybody can access it. So it's led to this problem. And I think we got to get upstream. We have to spend more time on education. The things we know determine health is less about medical delivery, and it's more about social determinants, your behaviors, your income, your education, and some of those things that we know are grounded in science. But I don't think the consumers or the patients really understand that. So patient engagement is important for us to know their numbers. They can help us engineer our way out of this, but we'll never do it on our own. We have to get upstream. We have to collaborate with school systems, city governments, employers, and I think that's the way forward. We have to take a longer-term view of this through our planning processes, but there aren't any quick fixes to this. And we have to go where there's like-minded people, community coalitions. I think the healthy community designations that are coming out of the UW Population Health Institute are positive, and I think it's creating awareness. And so if I'm not bumping into public health issues, I don't think I'm doing my job on the acute care side of delivery, because I think it's all about prevention in early detection and mitigating downstream illnesses. I think the Honoring Choices, La Crosse is a great example in having those tough conversations. And so we're in our infancy of beginning to have some of those conversations. And people understand, there's not simple solutions to these things, but we can't solve it inward. We have to push the front door of the hospital out into the community to make sure we're engaging many others.
Who needs to be in that room?
Yeah, I think city governments, employers, faith community, and we'll go wherever, employers naturally. And the hospitals, for me, have used to be a place you went to die and then a place to get well. Now it's a place you really want to avoid. And I think in the future, the least expensive admission is the one that never occurs. The healthiest patient is the one who embraces wellness and prevention. And I think some of those notions, while we're part of the problem, we have to be part of the solution. So I think we are just trying to convene and integrate many of those thought leaders in our communities.
I think it's, I'm not as well versed in population management, although I was once asked to do that job, and it took me a year to figure it out. But I think it has to be community by community. Whether that community is a county or it's Ford, I think what you said is exactly correct. I think most of the time it's going to be the hospital that's going to take the lead on that. the hospitals, and maybe the county medical society, maybe whoever is got the respect of the community members, with perhaps state money, with perhaps federal money, but I think each community has its own set of problems, and so it's got to be community by community, because that's where the bright spots are around the country, is when a community has come together and addressed those issues.
I would say that we have to do two things at the same time. Our policymakers and our employers need to realize it is a long journey. They want instant results. So we have to work on the healthcare costs going down for fast results, but they have to realize this is a journey and it's going to take time. And that will be one of the themes I hope comes out of the work group, to talk about the journey and what we can do in short term and 5-year bites, I would almost say. And the other thing I think will come out of it is, we haven't talked about it, but digital health is really going to change the way we provide care for every age. And I love it when people tell me, well, people over 65 don't understand the iPhone. I said, really? They're our #1 MyChart users in the country.
Oh, really?
Yeah, absolutely. So it's basically people have biases, and we have to start providing them opportunities across the whole spectrum. Opioid control will be helped by digital applications as well. It won't be cured, but it will be helped by that. So I think that will be one of the themes also that comes out, how we embrace digital health.
Jim, to pick up on these last 3 points, I think what you're hearing is we maybe need less of a planning process going forward, and we need an engagement and an implementation development process, which I'm nitpicking a little, because isn't that a form of planning? Sure it is. I guess what I'm saying, though, is I think if you polled 25 people out in the hall about what are the major health challenges facing the state, you'd get a pretty consistent list of things. We know what the problems are. We also know where to go and find the evidence base for what to do about those problems. What's missing now is, as Bud's alluding to, some additional conveners and real local leadership to pull all those necessary parties together to build that consensus around what's important and what should each of us do in our respective seats, our respective sectors. How do we build some more patience and a willingness to look at this over the long haul? So I don't know that we need to sort of throw the book open again for an entire reprioritization effort. I think we need to take what we've got and challenge ourselves to start there and move forward.
So let me say that I misspoke, and so you have to correctly describe what the intent, I think, of BeBoldIII recommendation is with this one question. It is, I think the healthcare community is clearly where you have described it. I mean, they've been thinking about it, they're engaging with it, the transition's been coming, they can see the future, the needs, et cetera. I'm not persuaded that all the other partners have reached that level of sophistication. Yeah. And so when we talk about engagement, and that is the plan, that is the activity that needs to take place, there's going to have to be an upgrading of their awareness of outcomes and how. So part of the question that I think is going to be important as we go forward is not just the need to talk to them, but what we talk to them about, and what we educate them on, and what their priorities. I mean, because the school systems, for example, they're locked into budgets, and money's only going certain pockets in certain ways. That may need to change in order to get the kind of outcomes that you're looking for. So
two quick thoughts, and then obviously others will want to weigh in. Two concepts to keep in mind on your point, I think, are enlightened self-interest and line of sight. So I think part of what you're describing, to take the second one first, there maybe are some organizations that don't feel like they have line of sight to what are the drivers of good health or bad health? What's my role as a school administrator, as an employer? Is it really my problem if my employee is drinking too much every Friday night? It's a Friday night, they're not at work. Why is that my problem? Well, it's my problem if and when it carries over into the workplace, right? And then the enlightened self-interest piece is, I think, to help each of those sectors begin to think about what are the ways in which poor health, poor societal conditions are influencing your ability to produce a widget, educate a child, hold a church service, whatever it is you're in, whatever that line of business is, you are being affected, whether you know it or not, by the conditions that are creating better or worse health in your community. So what can you do in that sort of next immediate ring out of your own self-interest to make conditions better for yourself, your customer, your student, your parishioner, whoever it may be?
We are at the end of our time frame, but I would once again like to go around the table. I'd ask you to think about a person or a group that you would like to say something to, keeping in mind that we're trying to reach out, okay? And tell them the one thing that you think they, just as they start to have a conversation about population health or well-being, that they might need to think about. And that's just what you just said, Karen.
I can say one more sentence, which is, I think to the employer community across all sectors, the health and well-being of your workforce matters to your productivity and competitiveness, and it is influenced by things that you may think are not within your control, but you can influence them by choices you make as an employer.
Great.
So I would say to the policymakers, we have an opportunity to address social determinants, which will lead into more people being employed, being healthy and working, and better quality of life. And it would be getting rid of our issues with food deserts and housing, transportation. Those are the fundamentals. We have to start.
Yeah, I put a plug in for something that Mike mentioned earlier. The just launched Healthy Community designation is deliberately designed to do much of what we were just talking about, and that is to recognize the good work that's taking place and then really take the whole state to the next level.
Okay. Good.
I guess the two groups that I would address my comments to are, one, my board. That'll get me in trouble. Two is the board of the Wisconsin Hospital Association, and say that you are the two groups that really need to step up and take a lead in the communities where you're active and push this forward.
Yeah, I was two things. Healthy Communities designation, I like that. I think that's got legs, traction. I think it's engaging county health departments, city governments, and I think it's what's right in convening, obviously, the local healthcare provider. I think that's going to become a status that's very desirable. I think they've been very thoughtful about that. So I would encourage those in communities to engage in that process. Secondly, I would agree with Karen. I think employers, what I would say to them is, we understand as a provider that most of you can handle a 2 or 3% annual wage increase for employees. It's this thing called healthcare that is out of control, double-digit increases. So as a provider of healthcare, we're also a purchaser. So we're trying to model the behavior. We're trying to be on your side. We're not only a part of the problem, we're part of the solution. So engage with us. We know this is a gift that keeps on giving to you in terms of better employment, presenteeism, less absenteeism, a healthier population. It's not mutually exclusive to have a healthier population and to spend less money on healthcare, and that's what we're after.
A couple of groups that I would like to target would be not only our policymakers, but I also would say some of our credentialing bodies, not only medicine, but nursing and others as well, because we're all in this together. And I think as what Karen was talking about in her description is the way that we help to insulate any family or individual or an aggregate is to have socially inclusive communities, and we're not there yet, and we're going to have to really take a good, strong look at how we address equity, and we're going to have to look at some of the judgments and the stereotypes and the biases that are currently in our policies that negate the ability for us to really put our arms around population health, because we're really talking about Maslow's hierarchy of needs, and in a humanitarian perspective, it really matters that each person or family or community or a larger town has that ability. So,
Let's give our healthcare professionals a chance to introduce themselves. Sir.
I'm George Quinn, Executive Director of Wisconsin Council on Medical Education and Workforce. It's a private foundation dedicated to improving Wisconsin's healthcare workforce.
Good morning. Tim Size, Executive Director of the Rural Wisconsin Health Cooperative. I've been around 40 years. It's a collaborative of also 40 rural local systems, focusing on shared services and advocacy on behalf of rural Wisconsin.
Morning, Eric Borgening, President and CEO of the Wisconsin Hospital Association. We've been around since 1920 and represent all of the state's hospitals and health systems, and are very focused advocacy organization when it comes to all things healthcare related.
My name's Bud Chumley, and I'm Chief Executive Officer of the Wisconsin Medical Society, trained as an obstetrician gynecologist, but retired from that.
I'd be curious what each of our panelists, how they would react to the subject and the need to address population health in Wisconsin. Dr. Chumley, would you go first?
Well, I think it's, as a physician, we're pretty much trained to take one patient at a time and do the best job we can. But when you start talking about population health, you have to look at the entire population, and you look at the community, and and not just the people that walk in your office. So it's the entire community and the entire state as a whole. So that takes you down a lot of different paths and a lot of different people involved in the community health, churches, community centers, and it takes us way upstream, as some people would say, in the health of the state. So it does take us into a lot of areas, which I'm sure we'll talk about.
You bet. And George?
Well, I think it's going to be difficult for us to meet the needs of our population in the future unless we look at bending that demand curve. There will be a gap between the supply and the demand of services and if we stay on the same track. So we'll need to look at population health improvement as a way to help bend that demand curve, if you will.
And Mark, you're looking at the big economic picture. So population health and impact, not only on your counties, but on Wisconsin's economic future?
Well, I've often said in county government, if you can stumble your way through your entire life and never really interact with county government in any substantive way, what that really means is that your life is probably pretty okay. When you need to interact with county government in some substantive way, it means you've had some ill befall you. I mean, you had some trouble in your life. Public health and the health of our population is one of those areas. And while we've had these troubles for decades, with today's technology, we know more about it. I mean, the hepatitis A, B, and hepatitis C, the illness du jour today, it's prevalent, and it's a public health concern. It's a major concern for the health of our population, and if our population isn't healthy, we really have very little chance of becoming economically healthy or positioning our state for future success. So the health of our citizens, the health of our workforce, the health of our families, the health of our children in the schools, critically important. And that public health is a big part of that.
Tim?
I totally agree with my three colleagues who've already spoken. I think what I would add to that is just an awareness of knowing in nationally rural Wisconsin, folks are older, poorer, sicker. There was a report that came out earlier this year that makes it very clear that rural communities are more likely to die prematurely from the top 5 causes of death: heart disease, accidents, stroke, cancer, and respiratory disease. What's really important to remember, it isn't, in fact, not at all because doctors, nurses, and others don't do a good job in rural. It's because people in rural do not take care of themselves as well as they have the opportunity to do. And I love the metaphor of going upstream, and that's what, if we really care about the health of our people, we need to go upstream and find intelligent ways to do that.
Eric?
I absolutely agree with everything that's been said so far. From a hospital and health systems perspective, population health is about broadening our view, our purview, if you will, and thinking not just about the sickness that we are addressing inside the walls of a hospital or a clinic, but the health that's taking place outside of those walls and before and after someone has an experience in a healthcare system. And so population health means a lot of different things to a lot of different people, but it's really taking on a much greater understanding and urgency within healthcare delivery systems. Something like 20% of the health status of a population or an individual is attributed to the actual care they receive. That the rest of that 80%, is attributable to other things like socioeconomic status and other things that affect population health. So for us, it means taking a much broader view of how we're interacting, being outside the walls of the hospital, and who we're partnering with and working with in those
Well, I was
worlds.
privileged, excuse me, Eric, were you done? I was privileged to do those interviews, and I never will forget the phrase one of the professionals used that population health in Wisconsin is a, quote, pre-existing condition. Can somebody talk about that and what that means and why, Eric?
I'll take a stab at that. I thought that was I saw those interviews and that stuck with me as well. Pre-existing condition. So one way to think about that is if you're purely in the mindset of a healthcare provider, physician, hospital, however you want to define that, and you're thinking about the patient that's presented to you, that comes into the ED, that comes into the clinic, comes into your doctor's office. Well, something caused them to come see you, and we're starting to much better not only understand the sort of dynamics that contribute to or cause someone to come into the healthcare system, and have a much broader appreciation of public health in that sense. So obesity, smoking, access to basic primary care, all of those things that are sort of showing up in the community health needs assessments that our members are doing annually really are painting a picture of a pre-existing condition, if you will, the condition of that patient, when they come in to the hospital, or what caused them to come in and have that encounter with a healthcare provider.
That term pre-existing condition suggests that many Wisconsin residents make poor healthcare choices. Anybody want to elaborate? First of all, do you agree? And anybody want to put that in context? Tim?
Yeah, I would Eric touched on part of it. And again, there is a rural-urban differential here in terms of getting sufficient sleep, amount of smoking, or any smoking, level of drinking or moderate drinking, maintaining normal body weight, physical activity. 5 key drivers for the major illnesses that in rural America we're seeing more of than we should.
Dr. Chumley, do you think the person coming in to see your physicians, generally, this is a broad brush question, is in worse health than she or he was 5, 6, 7 years ago? Maybe because of age or maybe because of some of these poor healthcare choices, sir?
No, I don't think they're in worse health. I think they're, in slightly better health due to, some things like statins, and, I think they're in somewhat better health. I was thinking of another way to go back to the population question, if you allow me. And, one way to look at population health, I was hoping that you wouldn't ask me first so I could get some ideas while you guys all spoke. But but if you look at population health, the greatest impact on population health in my mind was when we got clean water. And if you look at that, waterborne disease was a real problem. And then refrigeration came along. Those had major impact on population health. They cleared up a lot of problems. And statin is another one. We have statins now. Now that's a population health impact because we're reducing heart disease. Prenatal care has a great impact on the entire, population. So I think people are somewhat, the smoking rate is down across the teenage. We have less teenage pregnancies, and so I think they're somewhat healthier. But there are, so when we try to do something about population health, it's across the entire population, and it's getting harder because we've got the big ones out of the way: cleaner water, refrigeration, and so on. In undeveloped countries, it's a little easier because the big ones are still there.
I'm going to talk about the first recommendation that grew out of this, and that is noting the shift from a treatment volume-based reimbursement system to an outcomes-based reimbursement system. Here's my question for you professionals. How far along is this transition? Is it anywhere near completed? Can you see a date that it's going to be completed? Because this is, I agree, it's a huge re-emphasis, reinventing, turning things over. So,
it's early days yet.
Early.
The common metaphor for most of us in healthcare, given the financial incentives, we have kind of a foot in the boat, one foot in the boat, one foot in the dock. So it's very hard, and particularly in rural areas where we don't have the same scale. I think in rural, it's driven not so much by the finance, but the growing awareness it's the right thing to do.
anyone else on that
I think that's a
paradigm
good
shift?
No, it's a good point. I think it's a paradigm shift on paper, and I agree with Tim. Foot in two canoes, right? I do think that the notion of payment reform, for example, bundled payments, where a hospital or a health system is given one payment and then is at risk for that payment for that for that patient. That or readmissions penalties, which were obviously in Medicare and now being proposed in Medicaid. The way healthcare is paid for, and I gave two examples of two large payers, Medicare and Medicaid, is in part, I think, reframing for the better this discussion of public health, because you can kind of look at it as what are the inputs into the healthcare system and how does that affect the outputs of the healthcare system. And to the extent that healthcare is being reimbursed for a quality output, they obviously care more about what's happening on the input side. And that's driving, I think, a much broader and greater interest in population health, in part because it's the right thing to do and it's a responsibility that healthcare providers have in their communities. But to answer your question, it's kind of herky-jerky, right? It's gone a certain amount, but then we're seeing some things out of the Trump administration and HHS that seem to be pulling back on some of those types of payment reforms. So it's hard to say exactly, but I don't think there's any question that the notion of paying for outcomes, whether by government or on the commercial side, is driving a greater emphasis and focus on population health.
How much progress can one state, Wisconsin, make, given what the BeBold report calls the uncertainty in national policy making on health care? I mean, I hear a consensus, Jim, that we must act to address it, even given this national uncertainty?
That is clearly, I think, what I heard in the strategic planning sessions, that people, the assessment was that regardless of whether the policy was consistent or not, this shift was not going to go away.
Exactly. Yeah, I mean, if it's really hard to be productive if you spend a lot of time worrying about what's going on in Washington. So I think we just discount that. This has been a trend that's underway.
I'm just surprised, given that Washington writes the Medicare and Medicaid checks. Excuse me, but
Yeah, that doesn't mean we don't whine about it, but if we're going to get anything done,
Wisconsin must.
We must move forward. And I'll give you a good example. About 2 years ago, one of our members came to me and said, we got really help move our community forward if we had a more concrete way of demonstrating the healthy behaviors that people are partnering with across our community, across sectors. So I said, yeah, I think that's a really good idea. I think it's even bigger than what the co-op could do. So we went to the University of Wisconsin Population Health Institute, shared the idea, and after about 2 years of development, about 6 weeks ago, we launched something called the Wisconsin Healthy Communities Designation to do just that, to really acknowledge those communities that are doing a good job and to incent them to do even better. So we did the kind of traditional bronze, silver, gold. We paralleled our criteria with work that's been done with funding from Robert Wood Johnson for quite a few years on county health designation and on a culture of health prize. We were expecting, but actually shocked. We've gotten 40 applications from around the state, from counties, from multiple counties, from individual, probably it's down even to individual neighborhoods, probably more typically at a city level. I'm very optimistic that that is going to end up demonstrating to all of us that this does have legs. We are moving forward, and I think next year we'll probably even have 80.
Mark, you just got back from Washington?
Yes.
You're probably glad to be back, given
I
all
am
the...
glad to be back, yes. The reality of Wisconsin.
The climate in Washington. Is Washington not going to do anything on the two M's, Medicaid and Medicare, this year, given all that's churning in Washington?
Well, is Washington going to do anything on fill in the blank? I don't know about Medicaid, Medicare, but I guess I would say this. Wisconsin cannot afford to wait for Washington. We have challenges here. We've got smart people here. We've got creativity here. We've got folks that care an awful lot about the future of this state, and I'm not sure we have the luxury to wait for Washington to assist us in some way. I sincerely hope that they do. I think it's in the interest of our nation for Washington to do so, but we should not hesitate at all in pursuing our solutions here in this state without Washington.
Dr. Chumley, does your national organization expect any more efforts to repeal ACA, or is Washington going to stay away from health care, given all they tried to do last year? What do you think?
I don't think they'll do anything to increase the number of covered lives by insurance. which I think will back us up. I think there'll be less people covered. I don't think that means we should stop. I think there are a lot we can do because I think people, if they have a better sense of well-being, then they take better care of themselves, and there's a lot we can do in that area. Healthy communities is one of those things.
When you talk about population health, the BeBold report mentions factors, economic, social, and behavioral changes. Give me an overview of each of those and how they could make a difference in making the public aware of this population health need, what that one speaker called pre-existing conditions. These three factors?
Well, one would be the economic. I mean, I think that what comes to mind, the economic, if you have more money, you can buy better food. The food that is purchased when you don't have enough money is not the best food. That's been shown. I mean, you can buy a lot of calories at fast food restaurants, but it's not the calories that you need. That's one of the economic things. Okay. Fresh meat, fresh vegetables, fresh fruits cost more money. It's better for you, but it costs more money.
So that's economic, and that also is the behavioral piece.
Well, the behavioral piece, I think, is what we're talking about is that you need to exercise, you need to stop smoking, you need to be not overweight. But I think part of that is getting to being well-being, and we have a critical shortage of behavioral health specialists in the state, which I think it all ties together, especially in the rural areas.
George, what role could the council play on the issue of population health do you envision, please?
Well, I think a role similar to what we've done regarding workforce, which is to help inform the public, number one. Number two, to have the right players around the table talking about this issue and formulating solutions. It's a multifaceted question, as you've already highlighted. I'll make a controversial statement here. I think payment drives behavior. So payment to providers will help formulate solutions to this issue. Right now, providers to a large extent are paid on an episodic basis. So you see a patient, you get paid for that patient visit. Obviously, if you are paid for the health of that patient over an extended period of time or on a case-by-case basis, if you're responsible for that level of care, then you should be paid for that. And I think that's going to help drive a lot of these questions.
If I could piggyback on that, George, I want to, going back to something Eric had said when we were talking about workforce, the importance of the health care community owning the issue, but partnering with policymakers and others. And when you get to the policy, the public health issue, it seems to me that there are two issues, at least as I listened to all of this conversation over the last year. One is that the need is real in terms of both opportunity, which is to say to begin to get some better outcomes down the road. And it's real now because you don't get it until you start doing it, okay? The second piece was that when you think about the kinds of things that Dr. Chumley was just saying and that George was just talking about, it seems to me that you can't get the results you need if it's just doctors and nurses and hospitals and clinics in the field. You've got to begin to ask the question, you want to change behavior, it has to change behavior in the home, which means that there has to be a component that says, what does that look like? There has to be some access to the children, they're in the schools, and so that becomes a piece of the equation. County government is a piece of the equation here. And so I think that this idea, again, of healthy communities, and I know that, George, you're on this path, you look for broader synergies, you look for broader partnerships, and you ask, how does technology factor into all of that? So,
yeah, I totally agree, Jim, with what you said. But I want to emphasize it's a two-way street. It isn't just about healthcare providers getting the collaboration, Competitive Wisconsin or the Counties Association to help us do our work. Given the fact that education, employment, income are key drivers of the health of our people, I need to be more present working with Competitive Wisconsin. That's why I'm here today in part, with the Counties Association, Manufacturing and Commerce, the educators. Again, it's the issue of creating more synergy amongst our sectors, because I need all of those sectors to help me with health issues, but I also need to help them with education, with jobs, with income-related issues.
There's one other partner that's mentioned in the Be Bold report, and I want to read just a sentence from it. Comprehensive statewide public information and education campaign targeted at employees and employers dedicated to promoting adoption of proven best practice wellness and prevention care insurance plans. That's part one. So there's another partner out there that needs to be our employers and employees. But the part two, the cost of the campaign should be financed with state funds and tax-deductible private sector employer funds. This is one potential recommendation. Let's talk about getting potential buy-in from employees and employers, number one, and number two, the financing mechanism. Viable?
I think so. I know 10 years ago, I'm ashamed to say we probably weren't doing anything at all with our employees around wellness. And today, it's become a priority. In fact, at our last all-staff meeting, I was foolish enough to have a can of soda when we went into the discussion about what changes we should make. And there are quite a few people, even with me having my can of soda, said, well, we really should maybe take out the soda machines because we know there's a lot of detrimental things. So I think I've seen our employees, both line and management, begin to engage with this issue. But again, it's early days. And if we want to be serious, we have to make the investment in the data, the research, the public campaign to make it more normative.
Well, Eric and Mark, you spend the most time in the Capitol. Potential partnership and getting buy-in from the WMCs possible?
Well, I think there's a lot of ways to get employer buy-in, not necessarily emanating out of the Capitol. I can tell you unequivocally that many employers around Wisconsin care about healthcare costs. I mean, seems like a no-brainer statement. And as a result, are implementing a lot of strategies targeted at wellness, health, prevention. And we have numerous great examples of how health systems are partnering with employers, partnering with employers to keep employees out of the hospital, okay, as counterintuitive as that may sound. But there's a lot of reasons for employers to care about the health of not only their employees, but their employees' families and their communities, including being driven by overall healthcare costs. And I think Wisconsin's done some great work. Some of it being incentivized out of the Capitol, none of it. Some of it not at all being incentivized out of the Capitol, where we're seeing these great partnerships. The Wisconsin Technology Council just put out an excellent study called Better Healthcare for a Better Bottom Line, I think it was. And it has some great examples of that partnership that between employers and healthcare providers that are really delivering quantifiable and measurable savings. And I think it's there and it's flourishing.
I would just add to what Eric said. In addition to healthcare costs, we only have 70 employees. Every single one of them is really important to us to stay as healthy as we can. If we lose someone for whatever purpose for a week, a month, 3 days, that's hard, and that affects our ability to get the job done.
Mark, if the consortium came up with a specific plan, let me reread it. Campaign financed with state funds and tax-deductible private sector employer funds. No sale in the Capitol? Interest in the Capitol?
Oh, I think there'll be interest in the Capitol. I think Eric makes a very good point. If I might take this to the broader perspective for a moment. If we're going to be successful in this state, in our new millennium knowledge technology-based economy, where the number one resource for profit of the private sector is not necessarily steel, water, paper, pulp, but rather smart talent, smart young talent, but smart talent overall, we need to care an awful lot about that if we want to have a successful state. Well, one of the elements of that smart talent, the number one resource for private sector profit, and that's what we need for a successful state, is the health of our employees. That's why we have employers implementing wellness programs. That's how we have employers working with their insurance carriers to provide innovative solutions outside, as Eric put it, outside the Capitol. We don't need legislation for that. But at the same time, are there other things we can do to improve the overall health of the population? Education, the socioeconomic factors, which are major in terms of the health of a large segment of our population. Are there things we can do? Yes, this is one of them. This recommendation in the report is one of them. Is it saleable? It will take some education of our lawmakers, our policymakers, to understand how that can impact a successful state. But is it possible? Yes, I think it is.
And if I could just piggyback on that again, in the workforce recommendations, as you know, we have a recommendation that is premised upon the idea that tax revenues come when you fill a job. If you don't fill the job, you don't get the revenues. There is a similar argument to be made about quality health care and successful population health. The whole premise behind going to an emphasis on outcomes as opposed to paying per visit, as the case may be, is that will in fact reduce the cost of health care. But you can get a twofer. You get better quality and it costs you less money. That's part of the theory. If that's correct, there's a revenue stream that you can look at there. In addition to that, if we're talking about employers, as everybody has suggested, there are productivity questions involved. There's cost to them involved. So again, I think that part of the going forward here, as we live in this age of change, is to understand that if you do certain things, you get economic benefit from that. And on top of both of those things, if we don't do these things, we will not be competitive from a workforce recruitment point of view or from a workforce retention point of view.
Or a presence,
Or
workforce presence.
A workforce presence, okay? Right. So, or an employer group, yeah.
Dr. Shumley, as our population ages, is there a greater acceptance of the need to make better healthcare decisions? I know that's asking you to make an incredibly broad-based statement, but as our population ages, more of an awareness, things I could do to have better healthcare outcomes and avoid some of these critical diseases, the diabetes and the...
Well, I think just the closer you are to the end, the more you think about how much time you got left. So I think that there's a natural tendency to think, I wake up every morning thinking I better lose some weight because they've connected that to cancer and heart disease. And so I keep thinking, well, that's why I had yogurt and blueberries this morning. I don't like yogurt, I don't like blueberries. So, but what do? You know, you do. So I think we do think about it more. I don't know what Colorado has figured out, but you know, what do they do in Colorado? I mean, you ever fly to the Denver airport? I mean, they're all thin. You know, they drink less and they're not as fat as we are here. So is it the altitude? They're all, is that it?
I think, well, it's a piece of it, yeah, the demographic is different.
There's culture, too. Old enough to, wasn't that many years ago, I would say even 10 years ago, binge drinking was still a point of honor. I think due to a whole series of tragic deaths over at La Crosse, that community said enough already. Real men and women do not binge drink. So now, you know, I think binge drinking wasn't even something people talked about as a health issue 10 years ago, but now we understand it is an issue.
Well, as we begin to wrap up, one final question. Can we give people some sense of where all this is going and where we are in the process of explaining the population health issue as a major need to get better at?
Well, I'll take a crack at that one first. I think the main thing to understand is that the doctors aren't going to solve that, and hospitals aren't going to solve that, and the health system is not going to solve that. That the people of Wisconsin have to solve that. The communities have to solve that. It's all of us have to solve that, you know, problem going forward. This is not going to be solved by Medicare, Medicaid, better reimbursement. And it may not even be solved by if you give insurance to everybody, because just because you have insurance doesn't mean you're just not going to keep smoking and not going to get heart disease, and going to the doctor. You know, they can tell you. I can tell them as often as you got to stop smoking, you got to lose weight, and they just go on their way. You know.
Your counties have got to be identifying the growing cost of health care as a squeezer on their ability to provide services, correct?
Our public health, the elements of public health related to county government and our municipalities, the need is tremendous. The challenges continue to come. I think the doctor points out very accurately. It's not just an institution solution. It's going to be an individual responsibility solution. It's going to be an education solution. It's going to be taking responsibility for the actions of our individual families as we try to change our behavior. But there are challenges. There's a socioeconomic challenge. There's the financial challenge. There's the access to healthcare challenge. There's the access to education about what is the proper activity to engage in challenge. We have a lot of those challenges.
Excuse me. Okay. What about the mental health question?
Can I add to
Eric,
that
go,
last
please,
question a little bit?
please.
So we talked about payment reform and how it's driving increasing focus on population health. But I thought Bud made a very good point at sort of the 30,000-foot level, which is it's going to take a lot of people at the table. And while I think this issue of payment reform is indeed driving a greater focus by healthcare on population health, I'm going to raise a flag of caution, and that is payment reform can't absolve government from its role in population health. Payment reform has a potential of because a hospital or a physician or health system is going to be reimbursed now based on an outcome or whether a patient's actually readmitted to the hospital. There are a heck of a lot of circumstances that surround whether a patient is readmitted to a hospital that have nothing to do with the care that patient received. So, I think it's really important that as we continue talking about population health, we make sure that we are also talking about what everyone's role is in patient health as opposed to focusing on one sector or another and almost absolving government or others from their ongoing role in public health.
And I want to introduce, before we end, the question of mental health issues. Put that in perspective. We've been talking about dealing with diabetes and overweight, but the mental health question?
I'd like to start that off. I think we may have mentioned earlier the issue around opioid and drug abuse. There's a little bit of a debate nationally whether that is primarily from physicians who are overly aggressive prescribing. I think that was an element. I think maybe less so in Wisconsin. Personally, I like the language around an epidemic of despair. People who are most likely to experiment with drugs are those people who don't feel they have a future, where they're not able to get the education they need, they can't get the job or keep the job they need. So again, I think, to me, if we want to talk about the probably most major mental health issue of our time, the abuse of drugs and opioids, it's directly tied to issues around jobs, education, a sense of opportunity, a sense of living in a vibrant community. You just can't tease these things apart. We got to deal with them in a very systemic way, in a very kind of cross-silo way.
Are there any mental health professionals, generally in northern Wisconsin, who accept Medicaid patients?
If you can find a mental health provider, then maybe you'll find one that. The problem is Eric mentioned quite a while ago. I mean, we have such a shortage. You try to hire a mental health professional. Good luck.
Yeah, most of the. To answer your question directly, yes, if they're there. Most of the behavioral health providers, psychiatrists, others are actually employed by hospitals or health systems, and they're seeing people regardless of their coverage or Medicaid or Medicare. I think the bigger issue in behavioral health, in addition to the root issues I think that Tim's really talking about, is that it goes back to our previous conversation, which is the workforce. DHS is saying we have a 250 FTE psychiatrist shortage in Wisconsin, and they break it out by county, and you can see it's no. It should be no mystery that where we have some of the greatest shortages of psychiatrists and other behavioral health professionals, we have some of the most pressing problems when it comes to behavioral health care, as well as opioid dependency and other aorta problems.
Jim, you want to wrap this up?
Well, I would just, I don't, I'm enjoying the conversation. So.
I'm loving it,
But let me, I think the other piece I would put into, as we talk about the need for planning and expediting the process in population health, I would argue that we again pay attention to the data and think about this as a tipping point, a moment of opportunity. Roughly a quarter of the healthcare population, worker population in the state of Wisconsin is 55 or older. That replicates other professions, manufacturing, et cetera. Well, if you take that number and you got roughly 2.9 or 3 million people in your workforce, what we're talking about is over the next 15 to 20 years, essentially moving 500,000 people into our workforce, okay? That's a huge number. They're going to be, what are they going to be? They're going to be younger, they're going to be better educated, and they're going to be at least a quarter of that population, in my opinion, are going to be people we recruit, okay? So we and employers who are looking for healthy people with good habits and going to be productive, we have an opportunity to be proactive in this process so that we can say to them, we have this kind of community, which is what you want, because you're going to have millennials who are finally starting to have children and the next generation, et cetera. This is really, we should not let this just happen around us. We need to do this as an organized, systemic effort. I think that's what we're saying here, and I think the recommendation, and that's why the recommendation for a finite amount of money, it's not unlimited money, and it's a public-private mix, is to say, let's try to focus on this. Let's come together and see if we can't find best practices, if we can't promote and get bigger bang for the buck out of what we're trying to get done here. So that would be my parting comments.
Maybe one final question. What's at stake if we don't address the issue of population health? Eric.
I think that skyrocketing healthcare costs just come to mind immediately. We have to find out that, you know, so many things are plugged into the population health issue and vice versa. So, you know, if we're doing a better job of keeping the population healthy, that means we're theoretically reducing demand for healthcare, which alleviates some of the pressure on the healthcare workforce that we've been talking about previously. So I think there's a lot of ways to answer that question, but I think it really becomes one of access and cost, and something that we know we can address through just better utilizing the healthcare system.
Tim?
Yeah, I would repeat what Eric said, maybe slightly differently, but with the same idea. I think we will and can get more cost-effective, higher quality as healthcare providers. I quite frankly think over time the biggest change in terms of the overall cost of healthcare is by reducing the need for our services.
Mark, economic impact?
I would say, I would sum it up this way. If we want to define a successful state as more people making more money, engaged in more commerce with more opportunities, then we need a strong private sector. To get a strong private sector, you need the #1 resource for profit, which is smart talent. To get smart talent, you want a community which is supportive, which where they have the opportunities and tools necessary to have a successful family and a successful life. Part of that is a healthy community. Part of that is individual health. So there's the public health, behavioral health, mental health, population health. It is of critical importance, which leads to a successful state.
George?
I read an article this morning that said that 17 years from now, there will be more seniors than children in our country. Why is that important? Well, seniors, on average, 50% or more of seniors have 2 or more chronic illnesses, which makes this much more complex and difficult to deal with. So we see an expanding population that has a multifactorial set of problems. So if we begin to work on it today, then maybe we can help diminish that likelihood somewhat.
Dr. Chumley?
I think if we don't tackle population health, we'll just spiral down to a state of just utter despair.
Strong words. Thank you very much. Population health, critical issue. I want to thank all you gentlemen for your expertise. Thank you.
Thank you. Thank you.